for our World, here we go, for a World Symposium update. So the World Symposium happens every year. It usually takes place in either Orlando or California. And it is kind of an overview of everything that's kind of going on, but in rare diseases. But the great part is there is usually a lot of Fabry material. And so Dawn today is going to share that with us, the highlights, the overview. Now, those of you who have seen Dawn speak before, you know that she's she's very wonderful, and she can explain it in ways that are super easy to understand. Does a great review of everything. She's taking this entire week and she's just going to compress it into this 1 hour. So Dawn Laney is a genetic counselor. She's actually genetic counselor extraordinaire, and she works at, and she lives in Georgia, and she works at Emory. And she is, I just have it right here. She is assistant professor. And Dawn, I think is it genetic counselor trainer? Is that what the T is for? Yeah. In your GCT? Yeah.
Yeah. So yeah. Molding small minds.
Amazing. Okay,
young minds, not small minds. Big brains. Young ones.
That's right. Okay, well, without further ado, Dawn, I'll pass it over to you.
Great, thank you so much. So this year, World was again in San Diego, and this is the first time since COVID that it was back in person. So I was this is my first in-person meeting back, and I was kind of not sure how many people were going to be there, what it was going to feel like, but it turned out to be a really nice meeting with a good amount of people. So that was all great. And I'm very excited to be able to share with you some of the things that I learned. And I also put in a sprinkling of some things from the literature that didn't necessarily make it to World, but I think are still important as well. Okay, so let me share my screen here. Got some slides, because slides are always helpful when we're looking at this. All right. Can you see my slides?
Yes.
All right, perfect. Okay, so I'm just going to hop through here kind of quick. These are the things that I think are exciting from World. These are my disclosures. There's a lot of information that we get from World, so I'm going to try to condense it a little bit and tell you about the ones that are most exciting. And the way that I organized it, because it's on a lot of different topics, is I am going to do a little bit of definition. Not that I don't think you guys know it, but I think sometimes it's very useful just to make sure we're on the same page. Then we'll talk a little bit about things that we've learned about the impact on Fabry disease on people. Then we'll look at any new data on the therapies that are already approved for Fabry disease. And then we'll look at clinical trials, what information was provided at that meeting or shortly after it. Okay, so we all know that our cells are made up, our body is made up of cells. And in every cell, they've got different types. And two key types of cells are the filtering units called podocytes that are in our kidneys, whose job is to get rid of all the stuff we don't need and keep in all the stuff we do need. And those podocytes are kind of like little octopuses that live in our kidneys and do all the filtering. They actually look like this. We've also got the endothelial cells, and those are the cell types that line all the blood vessels in our body. And as you might expect, that's a lot of cells. But that's important because it lines our organs, it lines our blood vessels, and again, throughout our body. In all those cells, we've got the lysosomes, which are the recycling center of our cells. And then to tell us what to do and how to make those cells and everything within it, we've got our genes, which are the instruction manual for our body. And in Fabry disease, you know that the gene that when changed causes Fabry disease is on the X chromosome. So the X chromosome has got this GLA gene, and it's supposed to make the enzyme alpha-galactosidase A, which is then supposed to work really well and break down big giant molecules in our lysosomes. Alpha-galactosidase A is an enzyme which is kind of like the scissors, and the scissors should break down big giant glycolipids in our lysosome so we can use them again. Fabry doesn't allow that to happen. So with Fabry disease, we've got mutations or pathogenic variants in the GLA gene, and it means that it can't break down globotriacylceramide, which we call GB3, or the related gunk that builds up in there, other glycolipids like GB3. So lyso-GB3 is our latest one we measure in blood and urine. This gunk in those endothelial cells that line the blood vessels and the organs narrow the sides of the blood vessels, which causes problems throughout the body. innervates everything, right? So your blood vessels lined with endothelial cells go to your nerves. They go to the lining of your stomach. They go to your brain. So if the gunk's storing up, it not only decreases the size of the inside of these blood vessels, and it irritates it as well. So it does two things. The gunk stores and the gunk irritates. When we look at some of these studies, we're going to talk about classic Fabry disease and non-classic Fabry disease. We use these two terms, but remember Fabry disease can affect a lot of people in a lot of different ways. So we call it a spectrum, which means on one end we've got people who have classic Fabry disease, which means typically the men have enzyme that's under 5% of normal, and they have at least, they have pediatric symptoms, men and women, and we'd expect to see burning neuropathic pain. We expect to see corneal whorls, although not in everybody, and we expect to see angiokeratomas. And then we move across where there's people who've got parts of that. They may have childhood symptoms but may not have angiokeratomas, or they may not have burning pain. Until you get over non-classic, which is kind of the catch-all term for anybody who doesn't have symptoms in childhood or has more enzyme when you're checking in a man for more than 5%, but less than what would be considered normal. Which is just the long-winded way of saying everybody has Fabry disease and it affects them in a different way, but in order to do studies, you kind of have to classify them a little bit so you're not comparing apples to oranges. Because you said, look how well we did. We gave somebody this magical treatment and they didn't have symptoms in childhood. If they weren't expected to have symptoms in childhood, that wouldn't be a big victory. Now, if somebody's expected to have symptoms in childhood and that decreases that issue, then yeah, we're doing well. So just trying to compare apples to oranges when it comes to studies and treatment in Fabry. Okay, so what's the latest and greatest? Well, at World, they talked a little bit about newborn screening. So this is, when babies are born, no matter where they live, usually they do a little test, and the test is from blood on the baby's heel, and they test for different things. And in Brazil, Japan, and Italy, they went ahead and did newborn screening for Fabry disease. Now, that's not something that's standard in the United States. It's not something that's standard in all provinces in Canada, but it is something they reported on here. And the important take-home message is that they found Fabry disease in Brazil in 1 in 10,000 people of these babies. In Japan, 1 in 7,500. Then in Italy, they found 13 out of all the people in North Italy they screened. This is much more frequent than what we'd heard in the past, how frequent Fabry disease is. So it just tells us that there's a lot of people walking around with Fabry disease that don't know it. But what they did find in Italy is nobody had that classic childhood onset form of Fabry disease. They all had that non-classic form that you wouldn't expect to affect people when they're little kids, but would affect them earlier than what you'd expect to see in the average population. And it's been true through all the newborn screening that they have done in the US and Japan and Italy that we do see more of this non-classic Fabry disease than we do the classic, which kind of makes sense just because it's not as severe and you'd expect that to pop up more. We all have different variants, pathogenic variants that cause Fabry disease in GLA, and a lot of times we've got family-specific mutations or it's from one ancestor. Like in Nova Scotia, they have a founding mutation that's been there for many, many years. One mutation that we see across the world is a gene change we call N215S. And that's just the address of where the mutation is. It's in the 215th position, and it changes from the amino acid N to an S. So that's the address, like Sesame Street, except it's the address on GLA Street. And what they looked at is, when people have this gene change, we think of it as a non-classic change. So does that mean for real that kids with this gene change don't tend to have symptoms? So when we're talking about kids, we're talking about people less than 18 in this case. They studied their 19 patients who have this GLA mutation, and they said, okay, do any of them have symptoms? And the answer was none in the patients they looked at. They did find, though, that they had elevated biomarkers in 7 out of 9 of them. And this is a mix of women and men. But because everybody affects Fabry differently, Fabry affects everybody differently, and even with this N215S mutation, there'll be other modifiers that could cause different impacts on people. At Emory, we know that we have at least a couple kids who had symptoms in childhood of Fabry disease. So we're going to keep on watching, but it was very interesting that they did report that they didn't see symptoms in childhood for the people who have this gene change, because it's a real common one that we see a lot. This is a paper that I actually did. This is a study that was looking at little kids who have Fabry disease who were diagnosed from family history when they were under 3, or were just picked up through newborn screening when they were under 3, or just randomly picked up from symptoms. And the question that I was asking with this study was looking from the time, real time, so like right now, are you seeing any symptoms of Fabry disease in your babies who have Fabry disease? And we asked in boys and we looked in girls. And in this case, I just reporting data on people with classic Fabry disease, because as you remember, that's where we expect to see symptoms with Fabry disease when it's classic. And what we found is that the first symptoms that tend to be reported have to do with gastrointestinal issues. And the earliest ones are bloating, more frequent gas, and then flushing in the heat. So that's the biggest ones we see. But you also can see a pretty distinct pattern where it's at first they just have gas and more flatulence, and then it moves into diarrhea, and then it moves to abdominal pain. So it's almost like a pattern you can follow with the kids as they go from being a baby to being a 1-year-old, 2-year-old, 3-year-old. We also see they go from flushing to decreased sweating to no sweating, and that's over the first 6 years of life that I saw that. So it means that whether it's a girl or a boy, if they've got classic Fabry disease, we expect to see some early symptoms. Now, it doesn't mean you need to start enzyme replacement therapy in a baby, but it does mean we need to watch real closely to see what is that point where we need to start therapy at a particular point so things don't get worse. But again, just showing that Fabry does affect young kids. The average age it affected them was about 18 months, although sometimes people started the study when they were 3, which pulled up the age too. Switching gears from kids to pain. There was a really great paper that came out this year that tried to understand why pain happens in Fabry disease and what the types of pain are. So you can see that they just separated out really nicely into this graph, which I liked, that showed you've got pain that happens suddenly and is what they call acute, and then you've got daily pain, so chronic pain, pain that happens all the time. And so they've got those two bubbles, and then they overlap with belly pain, so abdominal pain. And they're saying you can have daily pain, abdominal pain, and you can have sudden onset pain. And they saw that. They also saw something similar with neuropathic pain, that's the burning pain. And they say it can happen because you're hot, because you're stressed, because you're sick, but it can also happen just spontaneously. So every day, no matter what you do, kind of pain. And I just like that it quantified and it talked about the different ways people can have pain. Because I think sometimes we assume everybody's talking about the same kind of pain when they talk about, oh, I've got a lot of, daily pain. And you're like, well, what kind? Was it abdominal? Is it hands and feet? Is it, this crisis pain? Is it daily, just the same level of, daily pain? So that was really just nice to see because I think it helps people understand better what this pain looks like in Fabry disease. They also found some papers that predicted that this is, of course, a small fiber issue, but also that it can be related to the ion channels, which kind of are supposed to open and close in a certain way to give signals across your nerves to tell your brain things. But they found that the ion channels can be malfunctioning in people with Fabry disease who have pain. Questions about those? That's kind of the natural history or just learning more about Fabry disease. Anybody have anything they're thinking of? You can store those up for the end or you can ask me as we go. Let's talk about what we learned about FDA approved, well, in this case it would be Canadian approved therapies. The first thing we learned is that starting enzyme replacement therapy earlier allows for better outcome. And this was a study that they did, this was the UK study, I do believe. Hold on, I gotta move my little thing here. Yeah, okay. So what this is a UK study, and they had 37 kids they were looking at, and before they started enzyme replacement therapy, 11 of them had burning pain, the acroparesthesia, neuropathic pain. 19 had symptoms, GI symptoms, so constipation, diarrhea, both the things, nausea, vomiting, the things you would expect to see in kids with Fabry disease. And then they started enzyme replacement therapy, and there was a range all the way from kids who were 5 to kids who were 15. So you can see the median, which means that's not the average, but if you put all the numbers in a line and pick the middle, it was 9-year-olds starting. And when they started in treating the men who were in this group, they then looked back at the pain and saw what pain do they have after therapy and what GI things do they have after therapy. So in the beginning, there were 11 kids that had that burning pain. After therapy, after therapy, there were 10 people who didn't have pain. So this is out of 37. So we're looking at, some that were improving and some that were worse. So you can see they just pulled the boys out of this one. So they're looking at 17, 21. 21 out of this were the boys. So you can see it didn't fix everything. And the question is that because there was kids who started therapy later, or is it because we always need to think about treating the pain as well as the underlying Fabry disease? I would say from my experience, you often need to start the enzyme replacement therapy, which can improve things, but often need to add a secondary medication to take away that daily pain or having pain crises. With the GI symptoms, 11 of the boys no longer had GI issues. 4 of them had a much improved, but 6 still had significant. Again, telling us that we can't ignore that GI pain and that we need to work on treating it. In this case also, it'd be good to know when they started therapy, if these were kids who developed GI stuff while they're on therapy or ones that had it from the very beginning, because you can see that only 19 of the regional kids had it. So interesting, just kind of an early view into the fact that earlier start of therapy does improve things for some kids, but maybe not all of them. The other thing that came out is Van der Veen, these are folks in Europe, they came out with this great paper that is the first time we've really seen a hypothesis about how much of an improvement you have the earlier you start therapy. So what they did is they made this giant arrow and they said, okay, let's start with things that are just markers that something's going on with organs, like proteinuria, bradycardia, and then starting to go into more and more significant symptoms, like moving into enlarged left chamber of the heart, that LVH, moving into a point where kidneys aren't working as well as they should, and the heart's got scarring, or there's arrhythmias, or mini strokes, and then moving all the way up to heart failure, strokes, renal failure, and of course the top is death. But what they looked at is using the data they had, when you start therapy, enzyme replacement therapy earlier, what does it look like? And what they showed here is that if you start enzyme replacement therapy, when you're at the point of maybe proteinuria and EKG changes, you can completely alter how quickly Fabry disease would usually progress. Now everybody's going to be different, everybody's going to have a different line, but if you start before LVH, they feel that's going to be the best outcome there. And you can see they move that arrow from looking at renal failure in the 40s, 50s, heart disease in the 40s and 50s, moving it into shifting it about 20 years. But then if you do it earlier, they're guessing that it's going to even flatten that arrow. Maybe they wouldn't move into some of those end organ problems. Now again, this is just a hypothesis based on the data they have, but you can see that symptomatic start of ERT does really move and improve how Fabry is going to impact somebody. But this is the first time I've seen a really nice graph that shows that earlier therapy is going to help more. Doesn't say that later therapy is not going to help anything, because as we know, even if your kidneys fail, if you get a new kidney, we can help your heart from having impact. If your heart's having problems, then hopefully we can treat that and keep your kidneys from having an impact. So, it's all different as we go here. Okay, so Fabrazyme is agalsidase beta, and there was one paper that came out from the Fabry registry, and it showed that in men with classic Fabry disease, when they get it every 2 weeks, they stabilize their kidney function. So that kind of supports what we were saying before, which is that early treatment is better, but if we can stabilize the wherever somebody is with their kidney function and improve the thickness of their heart, then that's going to be a good thing. So again, they saw better response in younger men, but for everybody it seemed to improve things. So that was great. And then there was a study that looked at infusion reactions, and they were trying to figure out how best to understand infusion reactions when it's not related to like anaphylactic shock, which is like when you get a peanut and you eat a peanut and you're allergic to peanuts and you say your throat closes and your swells and you get hives and all that. They were looking at something different. So if it's not that kind of reaction, the anaphylactic reaction, and it's not IgGs, which is what we spend a lot of time watching for when you're doing therapy, what is it? And they found that they didn't see a combination between people who have reactions during their infusion and those IgG antibodies. Instead, they found there may be issues with other types of immune cells, so like mast cells. And because of things such as autoimmune diseases, because of things such as chemotherapy, we've learned a lot more about how to control the immune system and decrease the reactions. So they were saying that they feel that if you've got a way to measure that mast cells are causing infusion reactions, then you can give medication that stabilizes the mast cells. So really this is just the first step in finding new ways to treat infusions other than Benadryl and steroids, which is what we do a lot of treating with. So just trying to find other medications that can help people who are not responding well to our usual infusion reaction medications. Megalostat, that would be Galafold. So one thing they found was that when people take Galafold, there is a decreased risk of strokes, renal failure, heart attacks, and all the other more severe manifestations of Fabry disease we tend to see as compared to the literature. So this is basically just saying that they found that people were pretty stable and were less likely to have these serious events when they're on megalostat over the long term. They also reported data on the studies looking at taking Galafold in kids. This is teenagers between 21 and 18, and they all had to weigh above 45 kilograms. But they found that it was well tolerated, and it looked like the medication was stabilizing their health as well. And so it got approved in Europe for use in people 12 to 18. It's not yet approved in the United States or Canada for kids, but this data hopefully will go in front of the right regulatory bodies and see if it can be an option for teens who have amenable mutations to megalostat. That's a pill, which is the reason that we care most about that. Let's think about clinical trials. So if you remember, we've got all sorts of ways we're trying to treat Fabry disease beyond enzyme replacement therapy, or what we already have. One thing is a pill that's called a substrate reduction therapy. I like to think of substrate reduction therapies as ways to clear the traffic jam in Fabry disease. So if you've got, if you're going down the interstate and you know there's going to be a big accident that's like 10 miles beneath you, usually what you're going to do is get off the interstate on an exit, go around it on the surface roads, and then you'll get back to your destination and have some scenic views while you're going. Substrate reduction therapy and Fabry disease, they're kind of doing the same thing. So you're trucking down towards the missing alpha-galactosidase A, you know that's going to block things and make the GB3 store up. So what you try to do is you try to get all those things that would become a GB3 to go down different metabolic pathways so they don't get stuck at the alpha-galactosidase A level. So that's what we're kind of looking at with this oral therapy, these pills. For venglustat, this is Sanofi substrate reduction therapy. It's already improved in Gaucher disease, which is one of our sister diseases. But it was gone through the phase 2 trials in Fabry disease. It's been a couple years. These phase 2 trials were only in men, and they had to have never been on therapy or been off for a really long time. And they treated them for up to 3 years. And their goal here was to see, is it safe? And that's what phase 2 studies are all about. Is it safe, and then does it work a little bit? But it's not really the does it work completely studies. What they found is that it does reduce the GB3s that are in the skin and the plasma, the blood, and people reported less pain, neuropathic pain and abdominal pain. So that was a great phase 2 study, and now they're working on moving to phase 3, which is where you continue to look and make sure it's safe and there's not really bad side effects. But then you also look at, is it as effective as other treatments? So that's where they're moving to now. So venglustat may appear as an option near you if you want to join a clinical trial. Remember that clinical trials are hard work and they're not for everybody. There's also substrate reduction therapy that was made by Idorsia Pharmaceuticals. This is called lucerastat. Same concept. We're trying to get all the things that might store up and block and make GB3s to go down different metabolic pathways before they get blocked. And they did a phase 3 study for Idorsia with the endpoint of pain, and they tried to very assiduously measure pain by doing apps and having people measure their pain every day. And they analyzed the data at 6 months, and they found that it was not bad side effects. There was reduction of GB3 in the blood, but they didn't see a consistent, significant decrease in pain after 6 months. Now, that doesn't mean that it didn't reduce pain. It's just you've got to look at average, and you've got to have it a certain amount reduced. And we just looked at all those different types of pain, And it may reduce one type of pain and not the other, but you can't measure that with these outcome tools. So we're going to see what they're going to do with lucerastat. Hopefully they've got that 12-month data to look at, see if maybe that did help with neuropathic pain. The FDA and other regulatory bodies are not looking at GB3 as a way to approve a medication right now. So they've got to figure out if they're going to continue working on this product or they're going to stop working on it. Even though it had good, it looked good with reducing the GB3 and it looked good at safety-wise. So we'll have to wait and see what happens with this. It's one of the problems right now in Fabry disease is how do you get the right data that the regulatory agencies are going to look at and consider that better than what's already out there, or at least having a great safety profile and worth pursuing. So the companies are trying to figure it out, but they haven't really figured it out quite yet. So stay tuned. We'll see what happens with lucerastat and idorsis. You may have heard, this is enzyme replacement therapy. There's next generation enzyme replacement therapy for Fabry in development. This is called pegunigalsidase. The goal of this medication is they have an enzyme that would make like a human, except it's made in plant cells. And you stick a pegylation on it. And the goal of pegylation is to stabilize that enzyme, keep it around your body longer, and also do a little cloaking so our immune system, it doesn't react to it as much. So we call it, it's PEG in the beginning of its name because it's pegylated. And then the galsidase is because it's a changed version of alpha-galactosidase A. So they presented their data at World on the study that switched people from Replagal to pegunigalsidase, and they were every other week. They had only mild or moderate infusion reactions, so nothing worse than what you'd expect with Fabrazyme. There were 2 patients who had severe ARs who chose to discontinue, but they showed that overall the safety profile was good, and it did keep the, at 12 months, it kept renal function stable as they measured eGFR. And they looked at slope, so what was changing and did it change faster or slower than what you'd expect. So this data is headed to review by the FDA and other regulatory organizations, and we'll see if they're going to approve it. They also just this week released their information on giving this medication every 4 weeks instead of every 2 weeks. And in this case, they said it was well tolerated, and they saw evidence that the medication was staying in the blood for the entire 4-week period, and nobody had antibodies to this medication. So that also will go in their package to the regulatory organization. They have another study that looks at every 2-week treatment that people switched from a galsidase beta, so that's Fabrazyme, to this product and see how stable they were from there too. So watch this space. We'll see what happens with Protalix's drug, which again, we'll see if it's an option for everybody and how it would make sense to switch. And this would be a discussion you'd have with your doctor if and when it comes approved. Any questions about the enzymes, megalostat, substrate reduction therapies? All right, let's dive into the big stuff. Gene therapy. We all know that this has been a golden time for doing gene therapy in Fabry disease. There's a bunch of people trying to fix this and solve this issue. What they're trying to solve is how do we get someone's body who doesn't make enough alpha-galactosidase A and they have Fabry disease, how do you get their body to make alpha-galactosidase A enough that you can decrease that gunk, those GB3s in the body? They've been looking at different ways to do it. Do you take cells out, fix them and stick them back? Do you inject something that carries the gene into the body and make like a little factory of making alpha-galactosidase A, whether it's the liver, the heart, somewhere else in the body? Do you try to repair it within the body? Like, what's the best way to do this? The things they're looking at is what's the best vector. Vector is just the fancy way to say, the car that's carrying the corrected gene or the different gene into the body. People looking at lentivirus, adeno-associated virus, we call that AAV. Just think of this as the car that drives the changed gene back into the body. How do we know if it works? Well, if this gene therapy is working, then you should have in the body increased levels of alpha-galactosidase A enzyme. You should have stable or lower levels of that gunk that builds up, the GB3. And you need to have no worsening of heart and kidney disease, hopefully. Of course, if you're further along the process, it's of course not going to change stuff that much. You want minimal side effects, so no big giant immune reactions. or issues with livers or kidneys or hearts. We want to see if it reduces pain and gastrointestinal issues, and we want to last as long as possible. So that's what they do with these studies, is trying to answer all those questions and make it work. We lost one of the gene therapy companies this year, and I'll talk a little bit more about that. But AvroBio was developing a lentivirus product where you had basically a mini bone marrow transplant. They would take bone marrow from an individual. They would correct the genes within that person's bone marrow, and then they would give it back to them after dampening their immune system. 4 other companies and more still working on AAV versions of giving gene therapy. But with with AvroBio, they did phase 1 study, and that was done in Canada, and the results looked pretty darn good. And then they expanded out and moved to Australia and the US to do some more studies. Again, with the goal of taking cells out, fixing them outside the body, and getting them back. Again, the phase 1 studies, they did it on 5 people, and they found that the alpha-galactosidase level was increased, and some of the people on that study stopped their enzyme replacement therapy, and the level was still high. And they had decreased GL3, and that was even for 42 months after they got it. Looked pretty good, no serious reactions. This is just an example that shows you that this is the data that they had, showing that the alpha-galactosidase A level when they got gene therapy shot way up and then slowly came back down, but it seemed to stay pretty stable at some point. Whether that was, and all these were, higher than what people had started out with, even though you can see with patient 1 it got low, it was still not as low as it had been before they did therapy. So that was good, and this is showing that the GL3s did go down for all these patients who were in the phase 1 study. However, the data that came out of the next phase of the study, the phase 2, didn't look as good, and AvroBio decided to cut the Fabry program. Now, I'm sure there's lots and lots of things that went into that decision, but they chose this year that they were going to close the Fabry program. Now, does that mean somebody else is going to buy up this technology and try something different? It might be. Does it mean that this particular methodology just didn't seem to work as well as they would hope? Yes, that's what happened. So we'll have to wait and see what happens with using lentivirus and what AvroBio had used for this, because they had licensed technology from somebody else who developed it. We'll have to see what happens. It hasn't been long enough to see the final story on what's going to happen here.
Mind if I ask a quick question?
Yeah, go ahead, Ryan.
AAV versus lentivirus. I don't know the difference personally. Is there a big difference? Are you able to speak a little bit to that?
Yeah, so there are different kinds of viruses. So, there's all sorts of viruses out there in the world, and lentivirus usually can carry really big things, so big. What they do is they take out the innards, and in this case, they were using lentivirus to infect a person's actual cells, but outside of the body. So they didn't inject it into a human and say, go find somewhere you need to be and inject it. So in this case, they were not using lentivirus to inject in the body. They were doing it all outside the body. AAV is used a lot with gene therapy studies. There's a bunch of different targeting ways. So there's, I don't know how many, but there's a lot of different forms of AAV virus, and each of them likes a different part of the body. So there's some that are targeted the liver, some that targets the brain, some that target the heart, and sometimes you can mix and match these AAV. So you take 2 AAV vectors and you kind of engineer them together, so they'll target maybe the heart and the liver, or maybe the brain and the heart and liver, maybe the muscles. So AAV is very flexible and has been used a lot, and they use it to directly inject into a person and target a particular section of the body.
Okay, so they don't take your cells out. Okay, perfect.
Yeah. So they just stick it straight in. And in this case, with AAV, they send a ton of AAV into the body. And they say, I'd like most of you to go to a specific organ. In this case, usually it's either it's either the liver or the heart. And it actually puts like a little circle of DNA that's not a person's DNA, but it's injecting into the cells, the liver cells or the heart cells, and then makes its own amount of alpha-galactosidase A without ever touching a person's individual DNA. So it's like an added bonus DNA into the cells instead of being part of someone's DNA. So they're not fixing someone's GLA gene. They're adding an extra bonus GLA gene in there. And that's what they're doing with this AAV that you inject into your body. Sangamo and 4DMT are the two ones that are open and enrolling, and they're using this AAV injectable into your body. Sangamo's AAV is a recombination of a naturally occurring 2 and a 6, and they're focused on the liver. So they inject it in your arm, and the job is for all these AAVs to go infect your liver, and not to cause problems, but just to stick in this extra circle of DNA that should make your liver into an alpha-galactosidase making factory. And so they've started their phase 1/2 studies, which means is it safe in humans is what they're looking at. And they started out with men who have classic Fabry disease, and people can be on enzyme or not on enzyme currently. They cannot be on Galafold. They have to be off Galafold. They're starting to enroll women in May as well. So that at World, they presented their early data from their first couple subjects. And what we're looking for is everybody's alpha-galactosidase level to go up and stay above normal level, and for their lyso-Gb3, their gunk to stay down. If they were on enzyme replacement therapy, there's no guarantee we can get it much lower than what enzyme had given them and cleared out. But so we want it stable in that case. And if somebody's never been on therapy, then you want it to go down to the levels you expect to see in someone who's been on enzyme replacement therapy. Second year for subject 1, their alpha-galactosidase level went far, far above normal. So they were way below normal. That gray bar is normal level of alpha-galactosidase A. They started well below normal because they have Fabry disease. And their first dose went shot them way up, and has kept them up, which is really exciting. And their GL3 are down. And they've been keeping that high level of alpha-galactosidase enzyme levels up for the past year. And they've shown some improvement in their heart. And the subject says his leg edema is a little bit better. So he's in long-term follow-up, which means we're going to follow him for the next 5 years and you'll get updates about how he's doing as we go through things. The next person who did it was subject 2. And subject 2 also got alpha-galactosidase levels that went from below to up above normal. They dipped down in the normal a little bit about 200 days after I got injection, but then went back up again. So not as amazingly high as the first subject, but still pretty respectable levels that are above the normal range. So this would be an individual who you would expect not to need enzyme replacement therapy. And you can see their GB3, lyso-Gb3 stayed nice and level throughout this. And now he's rolled into long-term safety too. And in both cases, no massive immune reactions for either of these gentlemen. Subject 3, he was not on enzyme replacement therapy, so you can see his lyso-Gb3 levels were pretty darn high because he'd never had any enzyme. And it pulled it down at least to the 50 level. So it's still not to normal, but it's down. Now he's only had this, let's see, week 36, so he's only been on it about 6 months now. So we'll see if he goes down lower, but you can see his enzyme level, although it's dipped down to the normal level, never went down to where it was before, and he's still holding at week 40 at having elevated alpha-galactosidase A levels. So looking good. And subject 4, similar story. So you can see from what they were presented at World, it's going the right way. Now, how long is this alpha-galactosidase A level going to continue? We don't know. Are there going to be other health problems because people got gene therapy? We don't know. We'll have to wait and see what happens long term. This is still people that we have to be so grateful because they are basically donating their body to science and trying this thing that nobody else has done. And we just have to keep on hoping everything goes well for them and that they keep having this high alpha-galactosidase A and low lyso-Gb3. And even if it's only for 5 years, boy, that would be a victory. So we'll just look and see. So the story there with their medication, which they call ST920, was they didn't see many significant events. So safety looks pretty good so far. They have elevated alpha-galactosidase A. People had improvements in sweat, some improvements in GI, some improvement in cardio, or it didn't get worse. So that was good. At least one person has stopped enzyme replacement therapy and still has high alpha-gal. So that's good too. They are still looking for the dose for Sangamo. For DMT, another gene therapy study that's open. This is again a phase 2, so really early stage. They have their medication 4D310, and they're targeted for the heart. So when you inject it in the body, they hope that it'll go to the heart and transform the cells there. So you have this little extra DNA that's making alpha-galactosidase A in the heart to go through the rest of the body. They've dosed 3 people so far at one dose in cohort 1. They did have nothing that was dose limiting, so it means nothing that said they couldn't go any higher in dose. All 3 patients did have antibodies to alpha-galactosidase A from their time with enzyme replacement therapy. Patient 2 had what's called AHUS, which is a fancy way of saying their red blood cells exited their blood vessels and clogged up the kidney and put them into temporary but not complete kidney failure. That patient did not need anything fancy for medications. They were observed, they gave IV fluids, but they did have to be hospitalized for observation. They recovered well, all their laboratory things improved, but you can imagine how scary that would be if you're the patient who had this experience. Patient 3 had kind of a milder form of this, but didn't need to be hospitalized. They just managed it outside of that with IV fluids and medications. So you can see that in this case, there was some unexpected events they saw. The person who had patient 2 had very high alpha-galactosidase A antibodies, the highest of any of these 3, and they're wondering if maybe that's what caused problems with him, that he just had a bigger immune reaction because he had more antibodies, but we won't know yet. And again, this is so early days, we don't know. It may be the patients they picked or who participated, it may be that this is what we're going to see, but we don't know yet. But we do know is that for patient 1, they got nice alpha-galactosidase A levels, and he was able to stop enzyme replacement therapy and still have very high above normal levels of alpha-galactosidase A, yay. And they also had decreased or stable levels of their lyso-Gb3, which is great as well. And then they didn't give such a nice graph for 2 and 3 yet, but just showing you that this worked well for patient 1, and then we'll still see more data on 2 and 3 as time goes on. Freeline presented data as well. They're not open in the US or Canada. They're only in the UK right now. They also have an AAV vector that's targeted for the liver to make the liver into a factory of making alpha-galactosidase A. They reported their data on the first cohort. They showed that they didn't have any major reactions. People had sustained, so stable levels of alpha-galactosidase A that stayed there for at least 2 years with patient 1, and patient 2 is doing pretty well there too. They did have a real brief instance of inflamed heart cells that they saw in both patients about 6 weeks after they took the gene therapy, but they didn't have any other issues and it went away. So that's something that they need to watch for in all gene therapy when they see things like that. So, what questions do you guys have about gene therapy stuff? And it was a lot of information I just threw at you, but any questions that I can answer for you on that?
Yes, I'm Guy Thomas from Quebec. I want to know if you, I don't know if it's Chris Casper. You know the Chris Casper? Okay, it is going with gene therapy.
So they have started doing CRISPR in different people, and in fact, I believe it's Taiwan, they're exploring it in Fabry disease, just locally, not with a company yet. At this point, the one problem with CRISPR-Cas9, which is a way to, for you guys that don't know, basically you've got your gene and it's got an error, and the job of CRISPR is to go through and correct that gene error by pulling in the base pairs that'll correct it, and using these little enzymes that cut the error and pull it out and then put in new base pairs. So basically it's there to fix whatever error is there. And they've been doing it, trying it in cells that they take out of the body, and they've been trying people they inject, but not in Fabry disease. And the reason for that is that when you inject CRISPR-Cas9 in there right now, it can go where you don't want it to go, and it can correct things that are not errors related to Fabry disease. So what they're working really hard at is to target it better, to make sure it only goes where you want it to go, and that it fixes only what you want it to fix. Because it could fix things that are not wrong, or it could hop itself in the middle of a gene that stops you from having cancer, or making your cells move into a cancerous state. So they need to fix they need to target it better, make sure it's not going to make any errors while it's fixing errors. So it's not quite there for Fabry yet, but people are working on it. So we just need to keep watching and see what the next generation of that CRISPR technology is going to bring us. Because as you might expect, if you can fix the error that are in the cells that you have, that might be a little bit better than adding extra cells in there that are, or extra DNA in there that's going to make the enzyme factory. It might stick around longer. Because, you know, if you inject something, this extra bit in the liver cells, and then they, you know, infect and their next generation has it, eventually though, those cells are not going to keep that little extra circle of DNA that's going to like reject it after a while. So that's what we need to learn is, you know, how long that goes on. It also means that people who get the gene therapy that's targeted to the liver need to make sure they don't drink too much or get cirrhosis or, you know, have hepatitis, things that are going to make your liver cells die faster. So that's what they're working on there. So good question.
Thank you for your answer.
Sure. What else can I answer for you guys? If you think of something, you're always welcome to email me. You can email Julia. You can email any of the CFA folks and they will let me know what your questions are. And then I have just, this is my new family tree. The last time my family took a picture in a magnolia tree that we did for our holiday card, it was when the child without a head was about 8 months old. And the giant child sticking out his tongue was about 4. So this is my updated family tree with my giant children.
Yeah.
I love it.
There was a good meeting this year, and hopefully I gave you some of the key things that they talked about with Fabry disease. I think the most interesting to me were the information about kids with Fabry disease and what they reported on the gene therapies.
Thank you, Dawn. Does anyone else have any questions that they'd like to ask before she goes?
I have one question, Julia.
Yeah.
Someone's been on therapy for, say, 20 years and no reactions, everything's smooth, goes great. And then all of a sudden, all these reactions start, like diarrhea for a week and just miserable. Does your body get immune to it, or is the Fabrazyme or Replica, whichever one it is, does that change something in your body over that time? Or like now he's on all kinds of medication to try and keep him from being sick, and like he's getting his infusion, he's ready to vomit, and you know, it's just terrible. So I was just wondering if there was any other cases of them seeing that.
I would say, yes, we've seen some people who've developed that where they've been going along fine for a real long time, they don't have any antibodies, and suddenly something has changed. We haven't figured out exactly why yet, but some of that work where they're looking at different immune cells and how it's different to them, like those mast cells, that's kind of been where we've been looking to see, is something different that changed with the immune system? Did they get, you know, an infection that suddenly changed how their body reacts to the enzyme replacement therapy? Did they, you know, in most cases, people haven't stopped and started, but we've noticed like during the shortage, when people stopped and started, they started having reactions when they restarted. But if he's really compliant, then it's just a question of what's different.
I know, and it seems to be escalating because he just got back. That's my nephew that has it. He just got back from the States, and while he was down there, for some reason, he said his stomach just felt like he was so bloated, and he got to a point after 3 days that he was so bloated that it was affecting his breathing, and he thought he could have been having a heart attack.
Oh.
So he went to the hospital, they did an EKG and all that stuff, and they just told him, no, you're fine. You're not having a heart attack. You're not going to die. So sent him home. So we still don't know what. It seems like it's just escalating.
It does. It sounds like it's just getting worse. And I think that's where, you know, it may be worth seeing if his Fabry specialist could work with an immunologist to see if they've got any ideas. Like some, because that information's out there now in the literature, they could find some of the information. Like Dr. Gokar Alpan has done a lot of work and published it, trying different things like those mast cell things. You know, Dr. Miriam Benikazami has also done some good stuff with immune reactions. And you know, sometimes we have to do things like give weekly infusions to see if that helps your immune system, because the more frequently you give infusions, it stops those ups and downs that we see when your ends up, because it goes high and then it goes low and it goes high and it goes low. So we have one patient we've been doing weekly infusions on, and it helped. We have some people we end up doing really long infusions on. So it all depends on what their doctor is comfortable trying out, and who they're game for talking to. Because usually if you're seeing a very specialist, they like to talk to other doctors about what's going on and how they can fix it.
Exactly. Well, he's back here now and he's got an appointment with Dr. West. So
yeah,
he's
in great hands with Dr. West. Dr. West has seen it all. So we have some great ideas for him.
Oh, thank you.
Sure. All right. Anything else that I can help you guys with?
If not, like Dawn said, please feel free to reach out to myself, or Dawn has her email there, so you can reach out to her as well. But thank you very much, Dawn, for your time, for your great explanations. I especially liked, I learned something from you every time, and this time I really liked how you explained SRT. I thought that was really cool, and that's something that will stick with me now. So thank you for that.
Oh, good.
Okay, everyone, have a great night, and thank you again for joining. This will be posted on our website, so if you'd like to rewatch it again, and we will share the link for you. So have a good evening, everyone, and thank you very much. Oh, you know what?
Thanks.
We just have, thank you, just a thank you.
Thanks, everybody.
Thank you, Dawn.
Thanks.
Yeah.
Night.
Bye.
Bye.
Bye.